Renal replacement therapy. Renal replacement therapy is necessary in order to sustain and/or maintain quality of life once renal function is no longer sufficient. 3 modalities of renal replacement therapy are available: hemodialysis, peritoneal dialysis, renal transplantation. Choice of treatment modality. Renal transplantation is the modality of choice for most patients where it is possible because both quality of life and survival are improved compared with dialysis. However, transplantation is restricted by the availability of donor organs, the suitability of patients to undergo the transplant operation and postoperative long-term immunosuppression. Hemodialysis and peritoneal dialysis are poorly tolerated by some patients. In those with substantial comorbidity, renal replacement therapy may be considered inappropriate by the patient and the family. This should preferably be discussed well before end-stage renal disease occurs. Conservative management to alleviate symptomatic complications of renal failure may include erythropoietin, management of fluid balance with diuretics and potassium restriction. With more advanced renal failure, a symptomatic approach is taken similar to that given to patients with any other terminal illnesses. The relative advantages and disadvantages of hemodialysis and peritoneal dialysis are outlined in Table 14. Hemodialysis. Principle. Hemodialysis involves circulating the patient's blood through an extracorporeal circulation where it is exposed to an isotonic buffered dialysis solution across a semi-permeable membrane. The patient's blood is obtained via a form of vascular access. The removal of toxins occurs principally through diffusion. Waste products at a high concentration in the patient's blood travel down a concentration gradient across the semi-permeable membrane into the dialysis solution. Removal of fluid occurs principally by ultrafiltration. Water moves from the circulation down a pressure gradient across the semi-permeable membrane into the dialysis solution. Dialysis machines control fluid removal by regulating transmembrane pressure. Some solute molecules move with water by convection. Practical details. Most patients in the UK receive 3 treatments of about 4 hours each week. There is evidence for a threshold amount of dialysis below which morbidity and mortality increase. There are national targets for measured dialysis adequacy, which are based on urea, small molecule, clearance. Increasing dialysis delivery for a patient requires either an increase in time on dialysis or greater dialysis efficiency. Improved dialysis efficiency may be achieved by using dialysis membranes with a larger surface area or by increasing blood flow through the dialysis circuit, where possible. Apart from dialysis adequacy, the major parameters to consider in hemodialysis patients include the following: fluid balance, removal of salt and water during dialysis to achieve a target dry weight. BP control should ideally be obtained by manipulation of dry weight in dialysis patients. Electrolyte balance. Different dialysis solutions are available in which the concentration of sodium, potassium, calcium, and bicarbonate varies. Removal of larger middle molecules. High-flux dialysis membranes clear middle molecules such as 2-microglobulin with greater efficiency. Vascular access is required for hemodialysis. The preferred form of vascular access is the arteriovenous fistula, AVF. Formation of an AVF requires an operation in which the radial or brachial artery is anastomosed to a vein, which is not always possible or successful. An AVF must mature, involving an increase in flow arterialization of the vein, before it can be used. This takes at least 6 weeks and the operation should therefore be planned well before dialysis is required. Other forms of vascular access, all of which are less safe than an AVF, include the following: temporary dialysis catheter, large bore dual lumen catheters inserted into the internal jugular or femoral veins. Used for acute inpatient dialysis, but not suitable for outpatient use. Tunneled dialysis catheter, large bore dual lumen catheters inserted into the internal jugular vein and tunneled subcutaneously to an exit point on the chest wall. A Dacron cuff that sits in the tunnel reduces infection rates, although infection remains a very significant problem. Suitable for outpatient use. Can also be placed in subclavian veins, femoral veins, or the inferior vena cava. Polytetrafluoroethylene graft. If native veins are unsuitable for anastomosis to an artery, then a graft can be used. However, there is a significant risk of infection if this route is chosen. Blood circulating in the extracorporeal system requires anticoagulation, usually with heparin, and many nephrologists prescribe regular low-dose aspirin for patients with an AVF as prophylaxis against thrombosis. Peritoneal dialysis. Principle. As with hemodialysis, peritoneal dialysis exposes the patient's blood to a buffered dialysis solution across a semi-permeable membrane. However, the blood remains within the body and the semi-permeable membrane is the peritoneum. Dialysis fluid is introduced via a peritoneal dialysis catheter. Removal of toxins occurs through diffusion and convection. Small molecules diffuse across the peritoneal membrane down the concentration gradient between the blood and the intraperitoneal dialysis fluid. Larger molecules tend to move through convection associated with the movement of fluid. Removal of fluid, ultrafiltration, occurs by osmosis. Water moves to equilibrate the osmolalities between the two compartments. Peritoneal dialysis fluids are manufactured to be hyperosmolar, using dextrose as the usual osmotic agent. Different concentrations of the osmotic agent enable control of fluid removal. The rate at which solutes cross the peritoneal membrane varies, and depends on the individual characteristics of a patient's membrane. Broadly, patients fall into two groups. Low transporters have a slow rate of solute removal and so require long dwell times, i.e. continuous ambulatory peritoneal dialysis, CAPD. High transporters have a fast rate of solute removal and therefore require short dwell times. High transporters tend to rapidly absorb the dextrose, thus losing the osmotic gradient and leading to poor ultrafiltration. Best suited to automated peritoneal dialysis, APD. With more time on peritoneal dialysis, the peritoneum tends to move towards higher transport. Practical details. Relative contraindications of peritoneal dialysis include previous major abdominal surgery, diverticulitis, the presence of hernias or chronic respiratory disease, and an inability to learn the technique. There are usually 4 exchanges of 1.5 to 3.0 L/day. The majority of patients receiving peritoneal dialysis in the UK are on a CAPD system. The regimen involves continuous cyclic peritoneal dialysis with several exchanges of 2 to 2.5 L overnight, each with short dwell times. After the last cycle, fluid is left in during the daytime. Often one manual daytime exchange is necessary. As in hemodialysis, clearance on peritoneal dialysis can be measured, and below a certain minimum level mortality appears to be increased. Increasing the amount of dialysis on CAPD usually involves exchanging 5 times daily, i.e. an additional daily exchange, but many patients cannot achieve adequate dialysis with CAPD as their residual renal function declines. Some achieve targets by switching to APD, but the majority require a switch to hemodialysis. A recent advance is specialized fluid using polymerased dextrin, icodextrin, instead of glucose. The polymer is not transported across the peritoneum, so ultrafiltration is greatly improved in fast transporters. It is more expensive. Patient survival on peritoneal dialysis is probably equivalent to that with hemodialysis. However, technique survival is markedly inferior to hemodialysis. The following factors are frequently involved in the failure of peritoneal dialysis. Ultrafiltration failure may be due to increased peritoneal membrane permeability, convert to APD, or membrane sclerosis, convert to hemodialysis. Recurrent peritonitis. Inability to achieve dialysis adequacy may develop as residual renal function declines. Renal transplantation. Principle. The principle is to implant a functioning healthy kidney that may be from the following sources: living related donor, sibling to sibling and parent to child are the most common pairings. Long-term graft survival is better with living than cadaveric kidneys. Living unrelated donor, e.g. spouse or friend, becoming more common in the UK. Cadaveric, heart-beating donors who satisfy the criteria of brain death. This has been the main source of organs in the UK. Cadaveric, non-heart-beating donors. Results are less good with high rates of delayed graft function. Practical details and complications. The possibility of renal transplantation should be considered in nearly all patients requiring renal replacement therapy. Suitability for transplantation depends on the following: patient survival issues. For example, coronary artery disease is common in patients with end-stage renal failure, may be asymptomatic and is associated with a high risk of early postoperative mortality. It should be sought in high-risk patients and intervention should take place prior to transplantation. Graft survival issues. For example, there is a significant risk of disease recurrence and graft loss in patients with focal segmental glomerulosclerosis. Resource allocation. Balance between maximizing benefit to each patient and the financial benefit of maximizing potential life achieved through each graft, i.e. death with a functioning transplant is not financially cost-effective. The UK Transplant Register is managed by the UK Transplant Support Service Authority and enrolls all potential transplant recipients. Allocation from the National Pool of Organs is on a points system, according to human leukocyte antigen, HLA, matching, donor/recipient relative age, time on waiting list, etc. Preoperatively, recipient serum and donor lymphocytes are cross-matched to detect preformed antibodies that would preclude transplantation. The transplant kidney is placed extraperitoneally in the iliac fossa and vessels are anastomosed usually to the external iliac artery and vein. The ureter is implanted into the bladder and a JJ stent is usually left in situ, which is typically removed after 6 weeks. Various immunosuppression regimens are used to prevent rejection of the donor kidney by the recipient's immune system. Most units tailor immunosuppression regimens according to the perceived risk of transplant rejection. Increasingly, a depleting monoclonal antibody may be given at the time of transplantation as induction therapy. Nearly all regimens contain steroids initially, but many units now withdraw steroids within the first year. A standard immunosuppression regimen would include a calcineurin inhibitor, cyclosporin or tacrolimus, steroids, and an inhibitor of purine synthesis, azathioprine or mycophenolate mofetil. Other therapies may include aspirin to reduce the risk of thrombosis, co-trimoxazole prophylaxis against pneumocystis carinii pneumonia and antibiotic prophylaxis. The complications of renal transplantation are summarized in Table 17. Outcome. The 5-year graft survival rate for first cadaveric transplantation in the UK is 64 to 72% and is partly dependent on the degree of HLA matching. Graft and patient survival with living-related transplantation is superior to that with cadaveric transplantation regardless of HLA matching. There is a definite survival benefit with transplantation compared with remaining on the transplant waiting list, although there is an initial increase in mortality in the first year after transplantation. Relative to remaining dialysis dependent, patients with diabetes benefit most from transplantation despite poorer absolute survival than other patient group following transplantation.